Dr. Wu, I'm Dr. Ubergeek, and I would like to tell you that I have researched since I've been diagnosed with a cataract and found you to be the doctor of all the doctors in the United States that I have chosen as the one that I want to do my cataract. Next slide, please. Next slide, next slide. And I just want to tell you what my life is like right now. I'm a golfer. I can no longer see my average 229.36 yard drive. Yeah, wait till you're my age. See if you can hit it 229.36. And the hardest part is being able to follow my ball on an overcast day up against the sky. Next slide. The other problem that I'm having is night driving. I have glare. I see these rings or halos around lights at night. Next slide. I work at about 24.32 inches from my laptop. Next slide. I'm about 13.2, I rounded off, inches from my smartphone. About the same distance to my iPad. And so, I've read about all the lenses, and with the miracle of modern cataract surgery, if you can give me all of these distance without glasses and eliminate my halos and glare, I will be ecstatic. But the one thing that I can't quite understand is with this miracle lens, why do only 8.2% of patients receive the miracle lens when they've been available for so many years? Dr. Wu, can you help me?
Well, Dr. Geek, it's such a pleasure to talk with you, or should I just call you Uber? And I appreciate your very thorough conversation about your life. And what I'm hearing from you is, even though you appear a little older, you're a very active, youthful man who has a lot of activities, and I understand that you're active in your, although you're retired and a retired engineer, you still have, you enjoy your hobbies of golf, and you drive at night still, and you use your computer and your devices, which, well, with the new iPhone, at least the good news is it's almost as big as the iPad. So that's good. But you have some serious expectations from this miracle lens, so I'd like to go through a little bit what your options are. And there's, by the way, not just one miracle lens, so you actually have options, so I thought maybe you'd like to hear about them.
Yes.
So the first category of lenses, which I think you're referring to, is the multifocal lens. And those will give you certainly the greatest independence from spectacles. And all studies show that. And distance vision is good and near vision is great, but intermediate vision is not quite as good with those lenses. So you may very well be in intermediate vision spectacles, specifically computer spectacles. And there's another category of lenses called accommodating lenses. And those are very good for distance and very good for intermediate, but quite variable for near. So you will be wearing near vision glasses with those, at least in dim vision and in dim light situations and with small print and when your eyes are tired, and the results are variable. So the downside of the multifocal lenses, if you don't mind the intermediate vision problem, is also that they're most likely to give you night vision disturbances. And if night driving is important to you, then that's going to be a problem, because all studies show that you're going to have halo and glare in a much higher incidence with those lenses. And loss of best spectacle corrected vision or contrast sensitivity. That's a problem for at least 6 months with those lenses. So you have another option, completely different altogether. You can have regular monofocal lenses, one eye for distance and one eye for near, and that's called monovision. And I'm not sure if you've tried that before, and we can certainly try that with you with the contact lens trial, since you have pretty good vision with your glasses. So we can do that and simulate it in contact lenses. And you generally have one eye for distance and one eye for near. And near can be defined as intermediate vision, or it can be defined as really near. You can choose the distance, and we can simulate that for you in contact lenses, and you can see if you like it. Not everybody actually likes that. Only 2/3 of people actually really tolerate that well, and you have to be able to shut out the input from one eye or the other. And people with monovision love it and are very spectacle independent, but they may have to wear glasses for night driving, and they may have to wear glasses either for intermediate vision or near vision, depending on the level of near vision that you set your near eye for. So we'd have to try that. So you seem like a very exacting person, and your last option is to have aspheric monofocal lenses, both eyes for distance, and wear that lovely set of frames with progressive lenses in them, and then you'll see very clearly at all distances, and that might be what I'd recommend for you.
Well, that sounds wonderful to me, because basically the one thing that I do not want to have under any circumstances are halos and glare. So it sounds like either the aspheric or you said monofocal. What's the difference between an aspheric and a monofocal lens?
Well, monofocal lenses can either be spherical or they can have different degrees of asphericity, which I'm sure you understand being an electrical engineer. So we would try to measure the sphericity of your cornea or asphericity of your eye, cornea, and since we're taking the lens out, then we'd try to match it to your particular eye. And I think that would be a good option for you.
Well, that sounds like the choice for me. And actually, with that aspheric lens, could we also do that little bit of mini monovision so I'd get a little bit too?
Absolutely. We can try it with contacts.
Dr. Wu, I'm ready to have surgery. Let's go.
Dr. Geek, it's been a pleasure.
First of all, I need to know, Helen, what's it like to be sort of queried and interviewed by Jack Holliday about aspheric lenses?
It's always an honor.
It's just like, being asked about the Bible by God or something like that.
Similar.
So let's deconstruct. You guys can stay right there if you like. Let's deconstruct the conversation a little bit. Panel, what did you like? One thing I noticed right from the beginning that I liked a lot is that Helen repeated or summarized in brief form the patient's concerns. Right? You said, so you want to see at distance, you want to see it near, you want to see it intermediate.
And we actually even use a form to make them write some of this stuff down so that afterwards when they're done, you can say, okay, this is what we agreed on, this is what you were looking for, and this is where we're at. So when they do come back and he can't see his 229.26 yard drive, he understands.
Right.
I think it was really important. I mean, Jack obviously took it to the nth degree, which we have patients that do that. By the way, those glasses do look really good on you, Jack.
Thank you.
But the fact that Helen right away said, your expectations may be a little unrealistic and described why and backed that up, I think was really important.
Also that Helen did a great job of explaining different options, especially to Uber Geek, who is an excellent and very inquisitive engineer. I think that a lot of our patients who are at this level need to have very, very detailed explanations, and I think that was really good as well.
Hi, my name's Dr. Donaldson, and I understand you're Mr. Pain in the Neck?
Yes.
Yes, nice to meet you.
Yes.
And what brings you in today?
Well, first I want to know that, have you gotten my records yet?
I have reviewed your records.
My records, I've highlighted them for you, and I've got them color coded just so you can go bit by bit by bit. And I want you to know a little bit of my problem.
Yes, okay.
And I know, I've got a pair of glasses. These are you like these glasses. I look really good in them, don't I?
Yes, right? You do.
Okay, well, that's my one pair. Well, this is the one that I read with. Okay, so I read with this one. And then I've also got my other golf glasses and then my other glasses. But the one that I've been wearing lately, these are my wife's glasses. And, I'm a lawyer, and I'm having to wear these glasses. And it's just really a challenge. But I found that when I wear these glasses, if I just kind of put them like this, it's that much better for me. And when I go in the courtroom, I can't go in the courtroom looking like this. I mean, what am I supposed to do about this?
Well, I understand you're really frustrated. And obviously you spent extra money and, you know, when you spend all that extra money, you have higher expectations and you're expecting perfection from your vision, and I'm sure that's what you understood from the beginning. So I can understand your disappointment. I think we need to work together to come to a solution here, okay?
And my options are what?
Well, I think we need to take this as a stepwise process. We need to rule out any possible problems that you might have. So we need to do some tests today. We're going to measure the front of the eye, because sometimes there can be problems on the surface of the eye called the ocular surface, such as the tear film. Your eyes can be dry, or the shape of the eye can be funny. So we make a topography or a map of the surface looking for astigmatism. And then we'll measure the back of the eye to make sure there's no problem in the back of the eye. Because all of those problems can cause these lenses not to function optimally for some patients. So let's rule out all of those problems, and then we'll make sure that your prescription is right on target. Because sometimes we have to do a little touch-up and enhancement procedure to help with that.
Okay, but first, I don't think you understand. Can you go to like the next slide? So I was on the internet, and I've been spending a lot of time on the internet, and this is kind of what I see at night. So these I can't hardly even drive at night. And, I work late hours sometimes, and then if you go to the next one, this is what I see during the day. There's like all these rainbow colors and all this just fuzzy stuff that I just really, it's disconcerting. And then I got one more slide for you that I got from the internet as well.
Okay.
And my concern is, how am I supposed to deal with this every day? My wife's getting pretty tired of me wearing her glasses first and foremost.
Sure.
But I think that, the problem that I have is I just can't get to where I need to be. And, this is getting a bit disconcerting.
Well, I understand that would be very disturbing. And I also understand, the internet is a great source of information for patients these days. So I'm glad you brought these images that you found on the internet to help me understand better what you're experiencing. The multifocal lens that you have inside your eye is not a perfect lens. It's the best technology that we have.
So you're telling me they put a bad lens in my eye? Is that it?
I'm saying I think you got the best technology for you that's available at this point in time.
Well, he told me I was going to see like everywhere in this lens, and it's not really working for me.
I understand. You meant to be like you're 20 again, but unfortunately our technology that we have available doesn't make us like we're 20 again, but it's the best we have. It can give you the highest degree of freedom from glasses. But you may get some glare and halos in some of these images that you showed me today. Can happen in some patients, but they usually get better with time.
So, but what are my options? Like what do you think I should do with this lens?
Well, I think we need to treat those things. We're going to do those tests today. We'll make sure we'll have to treat the ocular surface or any of those other problems.
But you're not talking about taking the lens out. You can't be talking about taking the lens out. Please don't talk about taking I'm about to lose my job with this thing. You just don't understand what I'm at. I'm probably the only person that has something like this. There's probably not anybody in the world that has it like this.
Yes,
as bad as me. I've got to be the only one. You think there's others?
There are others.
Okay,
sit down. I think we both need to remain calm here. We both need to remain calm here, okay?
I'm trying to remain calm the best I can, but it's really a challenge.
All right.
I thought I was like...
No, you're not the only one. There are other people out there. I'm going to show you a study that we did at Bascom-Palmer. And we basically looked at patients that sought consultation for dissatisfaction after premium IOL surgery. And we looked at 74 consecutive eyes of 49 patients. And of those patients, 77% had multifocal lenses, just like you have. And of those patients, when we looked at why they were unhappy, what we found was 57% of the time it was residual refractive error. And that's something that we can treat with an enhancement procedure, okay? 35% had dry eye, and again, that's something that we can work together to treat. So it's going to be a process. These things aren't fixed instantly. And then there were some other issues, like the 26% with complaints about their vision. So that also kind of falls into the category of what you were describing. And then other serious problems include 8% complications that happened during surgery, and it doesn't sound like that was the case for you, or another 8% with just unreasonable expectations to start with. So if we look at overall, residual refractive error is the most common thing, followed by ocular surface issues. So some of those things are easily treatable, so we need to start with just conservative things. Okay, we'll treat the conservatively first and use the lens exchange procedure as a last resort. But I think that, I think, if you and I think we need to work together to solve this problem. And if I can't solve it,
I have a very esteemed colleague I'd like to refer you to. His name's Dr. Stonecipher. He's really good with patients
But I hear
like
you're
you.
really, really good. And
Not
I
as
don't
good
want
as he is.
to. I don't
Not as
want to
good as he
leave
is.
you. You're not trying to tell me you're going to abandon me.
No, I'm not going to abandon you.
Okay. All right.
Hi, Mr. Bazinga. It's really nice to meet you.
Hi. I'm really excited about this opinion. I had surgery. I have some notes here, so I have a couple pages of notes. I hope that's okay.
Oh, love it.
So I had surgery a couple of months ago by Dr. Butcher, and Dr. Butcher said that if I paid extra for my cataract, that I'd be able to see like Superman, like see through walls and stuff. And I really love Superman. He's my third favorite superhero, although I think he'd be higher up on the list if his tights were a little tighter, I think. That's my opinion.
Yeah, Superman is clearly a favorite, Mr. Bazinga. But as far as your eyes are concerned, when I did the examination of your eyes, I noticed that the lens implants that Dr. Butcher placed are in perfect position. So I can assure you that Dr. Butcher did a great job with your cataract surgery.
Perfect? My vision's not perfect. The only thing perfect is my Meemaw. That's my grandma. You should see her with garter belts and high heels. She is really hot.
I'm really glad that you have a good relationship with your family there, Mr. Bazinga. But getting back to your eyes, your vision is correctable to 20/20, and so that's about perfect vision. I realize that's with glasses. But what I was saying is perfect, and those are very attractive glasses, I might add.
They got side shields.
Yeah. And so, but when I look at your eyes underneath the microscope, I can assure you that the cataract surgery itself was very well done. The lens implants are in very good position. The only problem that you have is called residual astigmatism. Astigmatism is the way that light is bent by the eye. And so for perfect vision, we need to have minimal refractive error. This means minimal need for glasses afterwards. And so perfect vision, light comes in, it's bent perfectly, and comes into perfect focus. When we have astigmatism, what happens is the light is bent at a different angle. And so this is the way that either your eye healed or the shape of your eye. Rather than being like a perfect circle, your eye is more like an egg, so the light coming in gets a bit twisted.
Twisted? That's so weird. That's the same thing my last 3 psychiatrists said about me. And my parole officer. He said I'm twisted too. That's so weird.
Yeah, well, it seems that you do have a little bit of a twisted vision, shall we say. But that's okay.
Thank you.
That's okay because we can actually help correct that. And so again, what I want to assure you is that the cataract surgery was done well, and I know that Dr. Butcher is a great doctor, and he will be able to help you reshape your eye to correct for this astigmatism. What I would recommend, based on my exam, is that you go back and see Dr. Butcher and let him do a PRK or surface laser procedure to gently reshape your eye, get rid of that astigmatism, or at least minimize it for you, and improve your vision in the distance.
Well, I don't understand. Why did I went online and I looked at all this stuff. This American Academy of Ophthalmology, they're all these magic machines they're selling, and they all give you perfect vision. How come my doctor didn't use that machine to give me perfect vision like they say, huh?
Well, we are ophthalmologists and not magicians, I might add. And actually, there is no magic machine. There's a lot of technology out there and a lot of very, very good machines. But even using the best calculations that we have, the best machines, top-of-the-line equipment, which I know that Dr. Butcher did for you, you can still have a less than perfect result based on how your eye heals.
Well, I guess, it's funny that when I was talking to Dr. Butcher about the surgery ahead of time, I mentioned your name and he said you were a Cadillac surgeon.
Well, I am a cataract surgeon. That's correct. I'm an eye surgeon, not a car surgeon.
He said you were a Cadillac surgeon. He said you had some fancy Cadillac and you had to do some expensive laser eye surgery. And he said, I didn't need that fancy laser stuff. He said he would just fix my astigmatism with cold, hard steel. It sounded kind of scary, but kind of liked it.
Well, Mr. Bazinga, there's many, many ways to do cataract surgery and also to fix astigmatism. And whether you do that with a laser or a blade, they're both very, very good ways of doing cataract surgery or astigmatism. And there's no one perfect way to do it. So again, whether Dr. Butcher used a blade or Dr. Butcher used a laser, you still may have had the same result. And again, that's the way your eye healed. But again, I would recommend for you to go back to Dr. Butcher, who I know is an excellent doctor. And the good news for you is that there's no vision that's been lost. Your your vision can be corrected, and there is a way for you, without going back inside the eye, to just have your vision gently corrected, and I think that you would get a great result.
Well, that's super. I really thank you for your opinion. I'm going to call Dr. Butcher's office tomorrow and set up an appointment. But just one more thing. Can I friend you on Facebook?
Oh, well, Mr. Bazinga, that's very, very sweet. And you can certainly friend our practice on Facebook, but I make it a policy not to friend patients.
Okay, thank you.
You're welcome. It was great to meet you.
Nice meeting you.
What do we think, panel? What do we like? What do we not like? What's your thoughts here? A patient who's referred in, very unhappy initially with the referring surgeon or the initial surgeon. What are the take-home points here, Kerry?
Well, I think the fact that she didn't throw the referring surgeon under the bus, and I mean, clearly there are instances where you may disagree with some of the things that you've seen, but in general, I think it is important to support our colleagues and make the patient aware and comfortable so that they know they can go back to their regular doctor with confidence.
So here's a case where there was truly some meaningful residual astigmatism. And she chose to be very upfront about that, although the patient had and paid for limbo-relaxing incisions in this case. How do we handle that? What's the subtlety of talking about an outcome that's not on target with another surgeon? The issue is more than just capsular opacity. Helen?
Well, it's important to say to patients that whatever modality used to fix astigmatism or refractive error is not 100% certainty, and we're not made out of plastic, and whether you use a laser or whether you use hard steel, there's still variability in healing, and patients do mostly understand that even one eye will heal differently from the other. They understand that, and it's important to make them understand that everybody heals a little bit differently, and it's not infrequent that you may need a little touch-up procedure.
Kendall?
Yeah, I think a lot of times we should actually tell patients in advance, if it is our own patient or it's just sort of a rule, that these cataract surgery is something that can be touched up postoperatively, like Helen was saying, and enhancement is quite common, especially when you're looking for perfection.
Good afternoon, Mr. Ictosis.
You can call me Hal.
Halitosis.
Exactly. I'm really very angry with you, and I want to talk to you about something that's really important to me.
Hal? I can call you Hal.
You can call me Hal.
Rule number 1, any patient who's in your personal space, beware. Hal, tell me, how's your vision? How are you doing?
I see you perfectly when I'm like this, but if I'm like this, you're blurry. Far away, everything's perfect. Up close, everything's perfect. But here, in the mid-range, you're blurry, and I can't live with blurry vision like this. I paid $5,000 for my cataract surgery. I was a +4 hyperope. I now have 20/20 distance vision. I can see J1 up close. Everything's fine. I can see up close, but intermediate is blurry. I mean, I wasted my entire investment in this. It's like I shouldn't even had cataract surgery because it was just worthless.
Well, Hal, I'm sorry that you're disappointed with your intermediate vision, and I want you to know that we're going to work together and do whatever we need to do to make sure that we can make your vision as good as possible.
You know, it's just not right. I mean, I wore this tie with eyeballs on it so you can see what I'm experiencing, but this eyeball is in focus. And how would you like to be a surgeon and your eyeballs are in focus here, but they're not in focus here? They're in focus here, but they're not in focus here, but they're in focus here and they're not in focus. I mean, how do you live with that?
Well, you know, here's an example, okay? We could shorten your tie. If I shortened your tie to here, I think that might solve the problem.
Do you really?
Bow ties are another option, of course. Again, part of my being helpful here.
Well, that's a great idea, actually. I like that. I never really liked ties. I spoke with my friends about cataract surgery, and my friends told me that I should really expect to see perfectly at all distances. And my friends told me that what they know about the surgery is that everything should be perfect. You know, I mean, how do you respond to that?
Well, again, the only question I would ask is who are these friends that you've been speaking with?
Well, Frisky and Susie and Bluebell. These are my cats. And I love these cats, and we speak regularly. They tell me I should be seeing perfectly.
How many cats do you have, Hal?
11.
Rule number 3, anyone with more than 3 cats, red flag.
I also want to talk to you, and that when I came in for my surgery with you, you told me I was a perfect candidate for surgery. You said that I was going to have a great result, that I had everything going for me. I was hyperopic, I had no astigmatism, I was a great candidate for these intraocular lenses, but your nurses told me they didn't think I was a good candidate. And how come your nurses told me I was a good candidate, a bad candidate, and you told me I was a good candidate? What's going on there? Can't you get it together in your office?
Well, let me just make sure we're on the same page. Your distance vision is really good.
Oh, it's perfect. I can see everybody out here. It's wonderful.
Daytime vision good?
I can see daytime. I drive.
Nighttime?
I'm seeing better than I've ever seen in my entire life. Far away. It's perfect.
How's your reading?
I read everything. Reading is great. I can read everything up close. Reading is just perfect.
Are you using glasses? Do you need glasses for reading or for your distance at all?
No. Aren't you listening to me? Everything is perfect. I can't see intermediate. You're blurry right now. I mean, how can you live like this?
Rule number 5, listen to your staff.
What do you mean by that?
When the staff says they're a bad candidate, listen to your staff.
So,
Hal, here's what I'm going to tell you. In general, you're doing very well. Your distance vision, I'm very pleased with that. I'm very pleased with your near vision. I do want to run a few tests. I want to make sure that the surface of your eye is healthy, that the eye itself from front to back is healthy. I want to look at the prescriptions and know this. We're going to do whatever we can do together. I'm in this with you every step of the way to make sure that you're getting the vision that you want.
You're not going to abandon me. I was so worried about that.
Rule number 6, don't abandon your patient unless it's Hal.
All right, thank you. Thank you very much.
Thank you, guys. So Carrie's first words after hearing the patient's complaint were, "I'm sorry." It was, "I'm sorry that you're disappointed." What do we think about saying "I'm sorry" to the patients? Oh, thank you for Fluffy's picture, everybody. Is this Fluffy? Okay, great. What do we think about saying "I'm sorry"?
Not good. You know, by apologizing and saying you're sorry, I mean, you want to sympathize with the patient, but I think that admission that you're sorry, I don't know that I would go that far as saying that.
Kira, you want to defend yourself, or anybody else want to comment first?
Well, he didn't say he was sorry for the situation. He said he was sorry that he was feeling that way. If our kids said that, we would be upset with them because it's not a real apology when it's our kids. But he wasn't saying that he was sorry that he made a mistake. He was saying he was sorry that the patient wasn't feeling well.
And that also indicated that he was trying to hear what the patient was telling him and empathize.
I really think it's important that we do tell patients. I'm sorry is a great thing to tell patients.
Let's get all the mics on, please. It's not.
I think saying I'm sorry is a wonderful thing to do. It's one of the things patients want to hear. I'm not saying I made a mistake. I'm not admitting any fault at all. But I'm simply saying that I hear what you're saying. You're disappointed with your outcome. I'm terribly sorry that you're disappointed, and let's work together to see what we can do to make this better.
It doesn't matter what follows it, right? That's, I think, the whole point, Eric.
In our office, we have a policy that works very well. Any patient who's unhappy after any cataract surgery, after any procedure at all, my staff is empowered to order the tests that are appropriate, that need to be ordered. So it's a topography, it's an OCT, it's a refraction, so that when I walk into the room, I know the patient's unhappy, but I also know what's wrong with the patient. I know where the problem is. And I walk in, and instead of walking into a patient who's unhappy, who has a chance to vent with me, I walk in and I say to the patient, first thing, you must be very unhappy with your outcome because I see the way you've healed, you have a dioptric astigmatism. We need to work together to resolve this because I'd be very unhappy where you are now, but I know that I can solve this problem with working together. So I never allow the patient to verbalize your displeasure with me, because once that doctor-patient relationship is compromised, I think it's very difficult to bring it back. So I want to never let that happen.
But and that's a great pearl, Eric, but you put yourself in that role to be successful because you've already got your staff trained to give you all the information up front. It'd be very different if you walked in, had to listen to the patient, and then say, wait a minute, let's order some tests, and let her fume in your office for a while. So I really do like that.
Yeah, and the one thing Kerry does real well, and I've seen him do it before, is he stays even keel. So no matter how mad the patient gets, no matter how much in his face he gets, it's still the same monotone, I'm here for you, I'm going to talk to you. One question for you guys. So let's say he's unhappy with his intermediate vision. You ever try contact lens trials to show him what it would look like if we change something? He could wear it for the day, go around. What are your thoughts on that?
Yeah, a simple thing would be contact lens trial is a great solution. A pair of glasses, if they've got a desktop computer, they can just leave a pair of glasses by their desktop computer. If it's a laptop, oftentimes it's just teaching patients to work within that sweet spot and let them adapt to that as well.
A lot of this also has to do with our nomenclature, how we talk to patients. When I tell the patient I'm implanting a multifocal lens, they expect to see everywhere. And I'm very clear with them, it's a bifocal lens. And you get near vision and you get far vision, and intermediate you may have to lean into things to see them and let them know, because when you tell something like that to a patient before surgery, it becomes an expectation. When you tell them after the surgery, now it's become a complication. So again, explaining to patients preoperatively and spending a little extra time can resolve these problems very well.
Eric, I'm glad you brought that up, because I will tell you, in the marketing material of a lot of the companies' information on these lenses, they market and it says to patients near, intermediate, and far, and everywhere in between. So the marketing messaging out there, I feel strongly, is incorrect. I don't even allow that sort of information to get into the patient's hands, because that is exactly probably where patients get the idea.
Right.
I want to move on and leave some time here for Dr. Mashat, who's going to clean up for us. Let's give a great round of applause for Kerry and Eric for that. Easy job.
You can't do surgery and not have a patient come in and be unhappy or have a complication or problem. That's just part of our lives. And, to me, it really is about, as we heard, one of the great pearls, listening to your staff, knowing who to treat, not to treat, what you tell or do for them before. In my practice since day one, which is going back almost 25 years, I always have a staff person with me when I talk to my patients. I always have that person taking notes. Patients see them take notes. So right away puts in their head. I also try and be incredibly clear. So I'm literally looking at every single person as someone potentially who could have a problem or be upset with me. I don't pull punches. I talk to them very clearly. I don't make guarantees. I've never had anyone, no matter what I've told them about complications, not proceed with surgery. What they're always looking for is, am I confident? Can they trust me? And that pretty much is all it. So I don't have to make it sound like things are going to be perfect. And by far and away, if I have any patient that has a complication, I talk to them. I talk to them right away. I talk to them on the table. I talk to them after. I'll bring their family and friends in, and then I'll set up to talk with them again the next day. I want to have that connection. If I have an unhappy person that comes in, like we heard today, and obviously these were all incredibly challenging patients, I kept thinking of what was going to go through my head, what I would say, and everyone was just phenomenal. I mean, we've all had patients like this. And I think everyone did it really well, which is I look at the patient in the eye and I shut up and I just listen. I let them voice their complaint. I let them voice their feelings. I make sure they know that I'm empathetic to what they're going through, and I don't stop and take notes. I don't turn. I've seen other doctors do that, and I've seen the way patients have taken it. So you want them to feel like they have your fully undivided attention. And like we heard again today, I echo their concerns. I make sure they know that I'm listening and I understand, and that I'm on their same side, that we're doing this together. We're taking care of it. I think what's really important I found is almost everything that I used to try and say, patients would always try and misconstrue or turn around. So I use the same terminology that Carrie used, which is, I want to make you happy. Because how are they going to argue with that? And I just repeat that. I want to make you happy. Whatever I can do to make you happy, I will do. And sometimes it's waiting. Sometimes it's technology in the future. Sometimes, it's trying different things. It's also the other big thing we heard is checking everything else, making sure we fully understand. Patients love, okay, let's be really thorough. Let's go back. Let's check right from the front of the eye to the back of the eye. People always want to know what's going on and what's the plan for moving ahead. That gives them peace. That makes them feel comfortable. That makes them feel that you're caring and you're taking care of them. The other big problem, which is very difficult sometimes, is patients will say things and it really hurts us because, we may feel like, wow, 20/20 distance, J1 up close, doesn't have intermediate, told them ahead of time, and you start to become defensive or argumentative. And that's the last thing in the world. You don't want to create any barrier or block between you and that patient. You always want them to feel you're on the same side. And I totally agree with Carrie. I have no problem saying sorry. I don't say sorry that I caused a problem. I say sorry. I'm sorry you're feeling this way. I'm sorry you're having these difficulties. And I don't personally have any issues with that. I want them to know I care. And that's really the key. Complications can and do occur. I had camera surgery 2 years ago, and I have to use that with patients. I tell them, look, 1% of people have a problem, 1 in 1,000 will have a serious problem. I had to sit there and think, am I going to destroy my career if I have a problem? Right? That's the same sort of risk. And I don't care if everyone else is okay. I care about me. And that patient understands that. So I put myself in their shoes. Overwhelmingly, the number one take-home message is patients sue when they don't like you, when you're not nice. That's the number one. When you avoid them, when you run away. They don't sue if they think you're nice. I tell people, I'm not a great doctor. I'm just really nice to my patients, and they love me for it. And that's it. Whether they have a problem or not, I make sure I'm there for them. So be nice. Thank you very much.